This is a simulation of fluid rushing through a mechanical valve. As the volume of the liquid decreases, the turbulence subsides. In clinical medicine, this simple principle forms the baseline assumption for how we evaluate heart murmurs. A murmur is the acoustic signature of turbulent blood flow. Intuitively, if you push less fluid through a restricted space, you generate less turbulence, and the resulting sound is quieter. Following this standard fluid logic, clinicians rely on a practical rule. If you decrease the flow of blood returning to the heart, a typical murmur heard through a stethoscope should reliably soften. We test this using the Valsalva maneuver. You ask a patient to bear down and hold their breath forcefully against a closed airway, which temporarily restricts that inward flow of venous blood. This split-screen diagram illustrates what happens next. On the left, a standard heart model follows the rules. Fluid volume drops and the turbulence indicator shrinks. But on the right, we see a hypertrophic heart. Here, the exact same drop in fluid volume causes the turbulence indicator to spike drastically. Differentiating a potentially fatal inherited condition from a benign flow murmur at the bedside doesn't require immediate imaging. It requires an understanding of the physics driving this specific obstructive gradient. When a murmur gets louder as the fluid volume drops, the physical architecture of the heart is dynamically changing under pressure. To understand this mechanism, look at this cross-section of the human torso. It maps the thoracic cavity, the heart, and the inferior vena cava. The Valsalva maneuver begins when the patient forcefully bears down. That action immediately increases the internal pressure throughout the entire thoracic cavity. This rising intrathoracic pressure physically squeezes the inferior vena cava, restricting the upward flow of venous blood from the lower body. Consequently, the volume of blood actually reaching the right side of the heart drops significantly. At the bedside, the Valsalva maneuver functions as a physical tool to temporarily turn down the faucet of venous return, deliberately underfilling the ventricles to test their response. This is a cross-section of the left ventricle in a patient with hypertrophic cardiomyopathy, or HCM. Notice the severe thickening of the septal wall right in the middle of the chamber. That thickened wall encroaches directly on the left ventricular outflow tract, the specific pathway blood must take to exit the heart. Even at rest, this exit route is dangerously narrow. When the patient performs the Valsalva maneuver and venous return drops, the overall volume of blood inside this ventricle decreases. Because the chamber is now underfilled, the thick muscular walls collapse closer together, physically pinching off the outflow tract almost entirely. The remaining blood must force its way through this drastically tightened gap. The fluid velocity spikes, generating intense acoustic turbulence. That spike in turbulence translates to a louder murmur in your stethoscope. In hypertrophic cardiomyopathy, less fluid volume allows the walls to collapse inward, creating a tighter physical obstruction. We can confirm this physical model by applying the exact opposite hemodynamic stress, having the patient squat down. This action mechanically compresses the veins in the legs. Returning to our left ventricle model, that leg compression forces a massive surge of pooled venous blood upward, rapidly flooding into the chamber. This sudden influx of fluid acts like water filling a balloon. The sheer volume pushes the hypertrophied walls outward. The blood itself acts as a physical strut, propping the outflow tract wide open and separating the encroaching septal wall from the exit path. With a wider pathway, the blood easily exits the ventricle. The fluid velocity drops and the intense turbulence subsides. When the murmur softens during a squat, it definitively proves that the internal obstruction is dynamic. The severity of the blockage is entirely dependent on having enough physical blood volume to prop the heart open. To isolate HCM, we have to contrast it with the primary differential diagnosis, aortic stenosis. This side-by-side comparison shows the dynamic HCM ventricular wall on the left and a rigid calcified aortic valve on the right. Aortic stenosis is a fixed structural lesion. The valve is stiff and cannot easily flex. Watch what happens when we reduce fluid volume in both models. The HCM wall collapses inward, but the physical size of the opening in the calcified aortic valve remains completely unchanged. Because that hole size is fixed, aortic stenosis strictly obeys standard fluid dynamics. Less fluid moving through a fixed gap creates less turbulence, resulting in a quieter murmur. A fixed structural lesion cannot collapse under low fluid volume. Its acoustic behavior sits in perfect opposition to a dynamic obstruction, making these simple bedside maneuvers highly accurate diagnostic separators. We can formalize these physical exam heuristics into a clean diagnostic matrix. The x-axis tracks our two maneuvers, Valsalva and squatting. and the y-axis tracks our two pathologies, aortic stenosis and HCM. For the standard fixed lesion of aortic stenosis, the murmur gets quieter under Valsalva and louder under squatting. For the dynamic obstruction of hypertrophic cardiomyopathy, the results invert. The murmur gets louder under Valsalva and quieter under squatting. By deliberately manipulating preload, you can reliably reverse engineer the hidden internal architecture of the patient's heart using nothing but a stethoscope. Most heart murmurs will quiet down when venous return decreases. When a patient bears down and their murmur intensifies, it is an explicit red flag indicating active, dangerous geometric changes inside the left ventricle. This decision tree outlines the protocol. If a murmur intensifies with a Valsalva maneuver, suspect HCM. That finding strictly warrants an echocardiogram and a cardiology referral. The echocardiogram is an essential tool, but it is reserved for this post-maneuver escalation to ensure targeted, efficient use of medical resources. Mastery of basic hemodynamics transforms a simple physical breath hold into a life-saving diagnostic tool. The most critical medical decisions often occur before the imaging machines are even turned on.